I am extremely happy and pleased to invite all of you for this distinguished lecture by Dr. Dinesh Kumar. And this is the first time a clinician is participating in a workshop, and he's going to deliver an excellent talk on the role of cytokines in cancer, especially pertaining to oral cancer. And for me to introduce the speaker, Dr. Dinesh Kumar holds a postgraduate degree in oral pathology, microbiology, and forensic odontology, and has 12 years of postgraduate teaching experience, and is currently pursuing PhD degree from the SRM Institute of Science and Technology. He was recognized as the best researcher by the International Society of Dental Research, ISDR, in the year 2011. He has published more than 40 papers in reputed journals and is serving as an editorial board member of Repute. He has in-depth knowledge of molecular techniques and is part of the serum and salivary biomarker research conducted at the department, and is experienced in proteomic analysis of saliva. So with this very brief and modest introduction, I would now request upon the speaker to take up the dais and give his talk. Thank you so much.
Thank you very much, sir. Thank you for the introduction. And before I start, let me know if I'm audible to all of you.
Yes, sir.
Yeah, okay. Thank you very much. So let me express my gratitude and thanks to Dr. Arvindan for extending this invitation to me and also to the higher administration of the university. A warm good evening to all of you. And this is by no means a comprehensive presentation. I have just tried to put in some basics on the clinical and histological aspects of oral squamous cell carcinoma and the role of tumor immunity in its prospective diagnostics and therapeutics. So let me outline a few objectives of this presentation. To understand the general definition of oral cancer, classification of oral cancer, to describe the clinical and histological features and diagnostic aspects of oral squamous cell carcinoma and pre-malignant disorders, to understand the basic immunology of oral cancer and its application in immunotherapy. And finally, to wrap it up, I will talk about a few cytokines, the diagnosis and immunotherapy, and what we do at our department related to these cytokines. Okay, so before I start, I want all of you to have a look at a video which is very familiar to all of you. Okay, so
ஏன் வாழ்க்கை இப்படி ஆகும்னு நான் நினைச்சு கூட பார்க்கல. எல்லாமே ரொம்ப நல்லா இருந்துச்சு. ஒரு நல்ல கணவர், 2 அன்பான குழந்தைங்க. ஆனா புகையில எல்லாத்தையுமே மாத்திடுச்சு. இப்ப இந்த பரவக்கூடிய கேன்சரை என் முகத்துல இருந்து வெட்டி எடுத்தாகணும். இப்ப எதுவுமே முன்ன மாதிரி இருக்காது. புகையில என் வாழ்க்கையை நாசமாக்கிடுச்சு.
கேனி, குட்கா, புகையிலை, சரதா, பான் மசாலா உங்கள் வாழ்க்கையை சீரழித்துவிடும்.
Yes. Okay, so now that was a very disturbing video, but many of us would have witnessed people passing comments and making fun of this. This is just not a regular advert, but a lot goes behind it for people to understand. Number one, the pain that goes in with the patient and their families, the efforts of the clinician and the surgeon in diagnosing and treating, and most importantly, the untiring efforts of researchers to understand the biology behind this devastating disease. Oral cancer probably is the deadliest human affiliation. The term cancer imparts a fear among the common man and even more to medical professionals because we still do not know where we stand, at least in terms of oral cancer. Oral cancer, as estimated by WHO, is the 6th most common cancer worldwide. Nevertheless, this term is synonymous with oral squamous cell carcinoma of the oral mucosal origin. Okay, so this is something that we all should understand. Carcinogenesis is a multi-step process which involves accumulation of both genetic and epigenetic alterations in oncogenes and or tumor suppressor genes. In the course of this progression, visible physical changes are taking place at the cellular level, which is actually referred to as atypia, and at the resultant tissue level, which is called dysplasia. And what clinicians see on the patient is an expression of an unseen process happening at the cellular level and genetic level. So in majority of the cases, what as clinicians we treat is the reaction, but not the action. Coming on to the general definition of oral cancer. So oral cancer is a cancer occurring in the oral cavity, which is basically an abnormal growth found among the mouth region. So malignancy which is occurring inside the oral cavity and affect this mucosa is what is called as oral squamous cell carcinoma. What you should understand is the term oral cancer is an umbrella term, which means it includes all the cancers which are occurring inside the oral cavity, out of which the majority or the major one is your oral squamous cell carcinoma. The ICD classification, that is the International Classification of Diseases, says that cancers occurring on the lip, tongue, buccal mucosa, gums, and alveolus, floor of the mouth, and palate are what are referred to as oral cancers. But this definition does not include the tumors of the salivary glands which are occurring inside the oral cavity and the oropharyngeal region. Oropharyngeal region is a completely different subset of cancer, which is usually occurring in the posterior part of the palate, that is the soft palate, the posterior part of the tongue, that is the posterior 1/3 of the tongue, and the pharyngeal region. See, why this oropharyngeal cancers are very important is because they've got a completely different etiological agent altogether. HPVs play a very, very important role in oropharyngeal cancers. So that itself is a separate topic altogether. So we're not going to touch upon HPVs as of now. So, but to understand what exactly this oral squamous cell carcinoma is, you need to understand a little bit of histology. I'm not going to details of this histology. The oral cavity, as you all know, is lined by an epithelium. The epithelium here is what is called as your stratified squamous epithelium. The reason why it is called stratified is because it has got multiple layers, number one. And number two, not just because of the multiple layers, you will also be able to differentiate each layer based on its appearance. Say, for example, the basal layer, which is here, is cuboidal in nature. The layer on top, which are called as spinous layers or the squamous layers. And finally, the most superficial layer, which is called as a stratum corneum. And within the oral cavity itself, there are areas where these squamous cells can differentiate and produce a proteinaceous product called as keratin. And some areas, they don't have keratin. Say, for example, your buccal mucosa, the same stratified squamous epithelium does not have the ability to produce keratin. Whereas in the hard palate and gingiva, this epithelium has the ability to produce keratin. So based on whether it is able to produce keratin or not, we will call it as stratified squamous keratinized epithelium or a non-keratinized epithelium. And another important thing that you need to understand is the membrane on which all these basal cells rest upon, or these squamous cells rest upon. So this membrane is what we actually denote as the basement membrane. So beneath which you have the connective tissue. So what basically this basement membrane is, this basement membrane is a delineating membrane which separates an epithelium from the underlying connective tissue. So this is what the basics, minimal basics that you need to understand. So as I told you before, what are squamous cell carcinomas? These squamous cell carcinomas are nothing but the cancers or the carcinomas which are occurring primarily from the squamous cells of the oral epithelium. So if those arise from the squamous cells, whether it may be a keratinized or a non-keratinized epithelium, so those cancers or those malignancies are what are referred to as oral squamous cell carcinomas. So this oral squamous cell carcinoma, as you all know, is an effect of multiple genetic mutations which are happening, which can either activate the proto-oncogenes or inactivate the tumor suppressor genes. So the resultant effect of these two, when the proto-oncogenes are activated, there is multiple proliferation. And when they inactivate tumor suppressor genes, which are supposed to remove the defective cells, which is uncontrolled, and then multiple division occurs, the resultant effect of these two is an uncoordinated fashion of proliferation cells, which results in a tumor, which is called squamous cell carcinoma. And in the oral cavity, of course, there are other types of oral cancers, as I told you. One, if it arises from a salivary gland, we call it as an adenocarcinoma. If it arises from a melanocyte, we call it as a melanoma. And if it arises from a lymphocyte, and because it's from a non-nodal region or extranodal region, we call it as extranodal lymphoma. This is just for your understanding, for you to understand. Oral cancer is an umbrella term which will include any type of cancer which is occurring inside the oral cavity. If it specifically arises from the squamous cells, it is called squamous cell carcinoma. And there are other types of cancers which are also there, which are adenocarcinomas, extranodal lymphomas, and melanomas, so on and so forth. So now in this presentation, we are going to restrict ourselves only to the oral squamous cell carcinoma. Now, coming on to the epidemiology of oral cancer, specifically in India. Okay, if you see, there are almost 13 lakh new cases which are happening every year. Okay, so this is the number of new cases as per the Globocan 2020 data. Every year, new cases are almost 13 lakhs, and the number of deaths every year is very, very alarming, which is around 8 lakhs per year. Now, if you take the gender-wise data of these cancers, if you see, in males, the most predominant cancer is the oral and lip cancer, which accounts for almost 16.2% of all new cancers. And if you take the combined gender, that is both male and female put together, this accounts for the second most common cancer, second only to the breast cancer. So that is how common this oral cancer is. Coming on to the etiology and the risk factors of OSCC. So as you saw in the video, so this is a very familiar thing that all of you know. The most common or maybe the only common reason is the use of tobacco. So the tobacco in any form, either be in a smoking form or a chewing form, is the most common etiological agent for oral squamous cell carcinoma. And in parts of South Asia and Southeast Asia, South and Southeast Asia, there are other forms of products which are also used, either in the form of this leaf, which is called as the betel leaf and the betel nut. Okay, so these are also used, so which we commonly call in Tamil as the vetala and the paku and the sunambu. So this is also another important product, but it is not a tobacco leaf as such. So this is the betel leaf. Okay, so this also has got certain compounds or products which can precede or which can lead to oral cancers. And the most important of all the etiological agent is one form of tobacco that we use in the form of powdered form. So these tobacco are used in chewable forms. So if you see the incidence of oral cancers, more than cancers which are caused by smoking, the ones which are more predominant are the ones which are caused by the chewing forms of tobacco. So all these three are established etiological agents for oral cancer. Apart from this, you also have alcohol, but alcohol, the role of alcohol is very debatable. Alcohol, there is no clear evidence that alcohol on its own plays a very important role, but when it is used in conjunction with tobacco, it has a synergistic effect where the alcohol can cause easy dissolving of the tobacco products and gain entry into the oral mucosa to produce its desired carcinogenic effect. Okay, and there is a new avenue which is called HPV. HPVs also are playing a very, very important role in the etiology of oral cancers as of now. But HPVs mainly cause cancers of the oropharyngeal region, okay, and the tonsils as well. So that is important one. And immunosuppression is another important factor which may predispose a patient for oral squamous cell carcinomas. Okay, so as far as the smoke or the tobacco products which are used, okay, so what you see here is a cigarette with its tobacco. So you will be astonished to know that there are almost 70 established carcinogens. I repeat, there are 70 established carcinogens which are known to produce oral cancers are present in this smoke. And if you take the number of chemicals which are there are almost 7,400 and odd chemicals which are there, out of which 70 are known to produce cancers, of which the most important is the N-nitrosamines that we all know. So this is the most profound carcinogen which is seen in the tobacco smoke. And recently, there is also high evidence for the bacterial populations which are causing oral cancers. So in the previous slide, you saw the tobacco which is used in a chewable form. But the problem with these chewable forms also have tobacco in them, but they are in the powdered form. But the only problem is the method of processing and manufacturing of these powdered forms of tobacco are not controlled in our country. So they don't have stringent measures on the methodology of preparation. So there is a lot of bacterial contamination which goes into these powdered products. If you go to North India, you see people on the road, okay, rolling all these tobacco products on the hand, putting in a small packet and giving it to you. So we do not know how much of bacteria which are there. So this is one study which is conducted by our department, the unit of our department, where we try to evaluate the number of bacteria or the bacterial populations which are present in smokeless tobacco products. Okay, You will be astonished to know there were almost about 2,500 species of bacteria which were present in the smokeless tobacco farms. Okay, and these tobacco, what does these bacteria do? What is the role of this bacteria in cancer production? So these bacteria, what happens is they have the ability to reduce nitrates. So when they reduce nitrates, okay, this will react with the alkaloids in the tobacco and they release a form of nitrosamines. So another study has showed the amount of nitrosamines, that is the TSNA, the tobacco-specific nitrosamines, are the highest amount in the Indian-made tobacco products rather than the Western tobacco products. The reason is, yes, of course, the methodology in which they are prepared. So this is the new avenue for research as well. Okay, so the role of bacteria, okay, bacteria in carcinogenesis. Okay. So now, as far as the we spoke about different etiological agents, but there are some agents which cause specific sites of oral cancer. Say, for example, for the lip cancer, the most common is sunlight and radiation. For the tongue, it will be betel quid chewing and the alcohol use. And for the mouth, cheek, and gum and other areas, of course, the betel quid and smoking. So these are site-specific etiological agents which are proposed. Okay. Now, as far as oral squamous cell carcinoma is important, what is very, very interesting to know about this oral squamous cell carcinoma? Okay. So the development of oral cancer is a tobacco-related multi-step process. Okay. So which involves a field cancerization, and many a times it is often preceded by appearance of certain lesions in the oral cavity, which we call them as potentially malignant oral disorders. So what I mean by potentially malignant oral disorders is they are not cancers yet, but there are some alterations, physical alterations which are happening in the mucosa, which will tell the physician, okay, that this particular area may turn into malignancy later if left untreated. So these lesions are actually called as potentially malignant oral disorders, or having the ability to turn into malignancy in the near future. Or we will talk about these potential malignant disorders. So what are the importance of this potentially malignant oral disorders? If you know that an oral cancer is preceded by such a lesion, and if you are able to eliminate these potentially malignant oral disorders, that would lead to complete eradication of most human cancers, suggesting that precancers are the most important lesions in modern man. Okay, again, I'm stressing why these are important is, unlike any other cancer in your body, okay, say for example, a gastric cancer, gastric carcinoma or a lung carcinoma, you don't have these preset pre-malignancies. But in the oral cavity, majority of the times, when we see these pre-malignancy, that itself is a red alert. Okay, so there comes a red flag that you need to monitor these patients for future progression of malignancy. Okay. So now, what are these potentially malignant oral disorders? These OPMDs, which they are abbreviated as, are the clinical presentations that carry a risk of cancer development in the oral cavity, whether in a clinically definable precursor lesion or in a clinically normal oral mucosa. So this is what the WHO definition of oral potentially malignant disorders are. And there are a variety of potentially malignant oral disorders. This is an exhaustive list. But what is very important is one on the left side, that is the leukoplakia, the erythroleukoplakia, the submucous fibrosis, and smokeless tobacco keratosis and palatal lesions associated with reverse smoking. A brief note on each. So the term leuko means white and plakia is a patch. So in your normal mucosa, your oral mucosa is usually pink in color. Suddenly, if there is a change in some part of your oral mucosa, if there is an alteration which appears white, then there is a possibility that it might be leukoplakia. Again, I need to warn the listeners here, not all white patches in the oral cavity are leukoplakia. So leukoplakias are those patches which are pre-malignant, and the etiology for those is usage of tobacco. But of course, there is an idiopathic form also. But it is always better to suspect and go wrong rather than not to suspect and go wrong. So these are white lesions which may occur in the oral cavity due to the usage of tobacco. In due course of time, this white patch will become a mixed white and a red patch, which is called as an erythroleukoplakia. That is, erythro means red and leuko is white. And finally, it will turn into a full-fledged erythroplakia, okay, which is fully red in color. And then there is another important condition which is called as oral submucous fibrosis, and this disease has known to be known to be caused as a disease of the Indian subcontinent, because every nook and corner you see people using all these tobacco products, and they have severe fibrosis of the connective tissue, and they have difficulty in opening the mouth, and they have burning. So this particular condition is called as oral submucous fibrosis. And there is something interesting that you need to know. Usually there is smoking which is happening where the lit end of the cigarette is outside. But there are in some parts of the country where the cigarette is used on a reverse side. That is, the lit end of the cigarette is inside the mouth. So that is called as reverse smoking, and this practice is very common in Andhra, some coastal areas of Andhra Pradesh. So those are called as reverse smoking. So the ones on the left side are very, very important for us to note. Okay. So now, which I've already described in the previous slide. So those lesions which are white appearing are called as leukoplakia, and those which are completely red are called as erythroplakia. And sometimes it will be a mixed lesion having a white and a red component, which is called as erythroleukoplakia. And obviously, yes, between these three, which is very bad, of course, the red signal here, erythroplakias have the highest potential for turning into malignancy. Okay, so now what is this concept of oral malignancy? So this concept of denoting some lesions or disorders of the oral mucosa or precancerous is based on the evidence that in some tissues where these alterations are present, they have undergone malignant change when they were followed up. And second is, and some of these alterations are seen to coexist at the margins of oral squamous cell carcinomas. A majority of the lesions share morphological and cytological changes observed in the epithelial malignancies, but without frank invasion. We will talk about frank invasion in the coming slides. And some of the chromosomal, genomic, and molecular alterations found in clearly invasive malignancies are detected in these presumptive precancer or the pre-malignant phase. So that is why, so a few of these lesions were actually referred to as pre-malignancies. As discussed before, if these lesions are identified early, it is easy to treat and prevent cancer. But these pre-malignancies also come with their own share of problems. So what are the problems associated with these malignancies? So usually there is a delay in the early detection due to limited patient concern attributed to symptom-free initial stages. The initial stages are symptom-free. In a suspected case, even if you do a biopsy is removing a tissue from the patient and looking for some cytological atypia or tissue changes. So suspected, the biopsy also does not reveal dysplasia. When it comes to treatment, majority of the cases, even when patients present to us in our clinic, when we see these pre-malignant lesions, what do we do about these lesions? Usually, we ask them to wean the habit or stop the habit. But just stopping the habit, okay, the usefulness of stopping the habit is questionable. But there are data which shows these leukoplakias, when the patient stops the habit, these leukoplakias can get back into normal tissue. So that is very, very important to understand. And finally, how do we monitor these cases? It is very, very difficult to monitor these patients to see if they are actually really turning into malignancy or not. Okay, so what are those factors or features that are associated with the risk of these PMODs turning into malignancy? Of course, there are clinical related factors, mainly the size of the lesion, the texture, and color is something which is very important. But what is very important is the histology, what we see at the cellular level. So what we call it as dysplasia. The presence or absence of dysplasia in this tissue will tell us whether this is going to turn into malignant or not. Okay, so that will be called as dysplasia, which will be evaluated for in a pre-malignant lesion to look for if it will turn into malignancy or not. Now, if you see this slide, okay, so you remember this, the ones which I put it on the left side, the leukoplakia, erythroplakia, speckled, and oral submucous fibrosis. If you see, the risk of malignant change of all these are very, very high. But for the other ones which was there on the right side of the slide are low. So these are the lesions which are very, very important and need to be addressed at a very, very early stage. Okay. So what is the rate of these malignant changes? So the leukoplakia, the mean global transformation is 1 to 2%. With presence of dysplasia, it goes up to 12%. Okay, if a dysplasia is present, the chances of those lesions turning into mass malignancy is almost 12%. So now let us talk a little bit on epithelial dysplasia. I talk about dysplasia. What is dysplasia? And I said that is how we find out whether these lesions are turning into malignancy or not. Dysplasia, the basic simplest meaning of dysplasia is, dysplasia means disordered cellular organization. Okay, so the disordered cellular organization is what is basically means by dysplasia. So it is characterized by a spectrum of architectural and cytological changes, which you will be seeing in the subsequent slides. So dysplasia basically means the disordered cellular organization, which is seen as an architectural change in the epithelium and cytological changes in the individual cell. Okay, and what is very important from your point of view, I suppose I was told you're all MSc genetics students, so you will be more interested on the genetic aspect of this. So what is most important is all these changes are caused by genetic changes. Yes, like a squamous cell carcinoma, there are also genetic changes which are there. Okay, so this PMODs from the evolution of normal mucosa to a oral squamous cell carcinoma. How does this happen? So it is a multi-step process. The development from a normal cell to a cancerous cell is a multi-step process of clonal evolution driven by a series of somatic mutations that progressively convert the cell from a normal state to a precancerous state to a cancerous state. Okay, so on the left side you see a normal epithelium. Okay, imagine a patient with this normal epithelium uses or abuses some form of tobacco. In response to this tobacco, initially this tobacco is considered as an irritant. In response to this, the epithelium starts to proliferate, which we call it as hyperplasia. But at this particular point in time, there are no genetic alterations. But continuous usage of these tobacco and the presence of carcinogens causes genetic alterations to happen in the cell and will result in a condition called dysplasia. And this dysplasia can be categorized into mild, moderate, and severe. We'll talk about mild, moderate, and severe later. Okay, so this is mild, moderate, and severe. And finally, a condition which is called as carcinoma in situ, where all the cancerous findings that we see in the cell are restricted to the epithelium, but they have not invaded into the underlying connective tissue. And finally, there comes a stage where all these alterations and the epithelium attains a certain phenotype and genetic alterations where the epithelium pinch off and enter into the underlying connective tissue, where a phase we call it as an invasive carcinoma. So this carcinoma is the movement or the migration of these epithelial cells into the underlying connective tissue. So if these epithelial cells from here have to go into the underlying connective tissue, there are two important things that the epithelial cell needs to acquire. Number one, basically the epithelial cell are all tightly held to each other. So if they have to move, they should, number one, okay, attain a motile phenotype, or they should have the ability to keep moving, number one. And number two, in the initial slides, I told you the basement membrane, which is very, very important. So they have to have the ability to breach this basement membrane and enter into the underlying connective tissue. So the hallmark, if you say, okay, so before the hallmark, okay, so this has to go into the underlying connective tissue, which is basically the hallmark of oral squamous cell carcinoma. That is a breach in the basement membrane to enter into the underlying connective tissue. Okay, so now coming into the oral epithelial dysplasia, the architectural and the cytological findings, I'm not going to details of that because all these are pink and blue, which I think it will be very difficult for you to appreciate. So these are the few architectural changes that are actually seen in dysplasia. The epithelial loss of epithelial stratification, loss of polarity of the basal cells, the drop-shaped retiridges, the number of mitotic figures which are increased and abnormal mitotic figures as well, and premature keratinization which is happening in a single cell. And coming on to the cytological features, which means in individual cellular changes, you see an abnormal variation in nuclear size, variation in nuclear shape, cell size, shape, cytoplasmic altered nuclear cytoplasmic ratio, and nuclear hypochromatism. So based on these features, we grade this dysplasia into mild, moderate, and severe. Okay, obviously the picture, it's a self-explanatory picture. The one on the right is a red signal. The severe the dysplasia is, the more the chances of turning into malignancy. So what is mild dysplasia? If all these architectural changes, if all these architectural and cytological changes, if they are restricted only to the basal 1/3 of the epithelium, if you take this epithelium from bottom to top, and if you divide this into 3, okay, so if these changes are restricted only to the bottom 1/3 of the epithelium, you call it as mild. If these changes are seen up to The middle 1/3, they are called as moderate. And if the entire epithelium up to the top portion, if the changes are seen, it is called as epithelial dysplasia. Okay, so if you see the malignant transformation rates based on the dysplasia, you can see the highest is for the severe dysplasia, which has got a 39% of chances for turning into malignancy. Okay, so this is what I was talking in the previous slide. So what is the hallmark of the histopathological feature of oral cancer? So now, although all these changes are happening within the epithelium, we will only name them as dysplasia. They have not yet called as squamous cell carcinoma. So the stage comes when we want to call it as oral squamous cell carcinoma is when the basement membrane is broken down and the epithelium enters into the connective tissue. You can see islands of these epithelium which have entered into the connective tissue. Now, this is a very, very important factor that you need to consider, okay, when we talk about therapy. Now, all these while the epithelium was separated from the connective tissue by a basement membrane. But suddenly these epithelial cells have pushed and encroached and come into the connective tissue, which is basically a foreign land. Okay, so it is not there. It is not their palace. Okay, so they've entered into a foreign land. So which means they have to survive the attack of all the immune cells which are present in the connective tissue. Okay, so this is very, very important from your aspect. Okay, so once it enters, now this epithelial cell or island comes or is attacked by all these inflammatory cells, all these immune cells which are present here. So they need to become self-sufficient and they have to escape the immune cells in this new land. Okay, so that is very, very important for you to understand. Coming on to the clinical features, I'm not going to details of all these clinical features. Okay, so at least for your understanding sake, okay, generally patients come and ask, sir, what is the when do I know that I have a cancer? The most important sign is when patients have an ulcer. Okay, an ulcer, again, there can be a lot of ulcers in the oral cavity. An ulcer, a non-healing ulcer for more than a month, an ulcer which does not heal for more than a month, okay, is a red signal which needs to be addressed. Okay, so an ulcer which is non-healing is very, very important for us to think in terms of a oral squamous cell carcinoma, and we need to address that issue. And there are also other ways by which they can present clinically. It can have a white area, or it can have a red area, or it can have a mixed red or a white area. And very frequently they have fungating exophytic masses, and they can also present as a swelling. Okay, so now that we have made the diagnosis, okay, from a clinical point of view, we've made a diagnosis of oral squamous cell carcinoma. So what next? The biggest question is, what will be the success of the treatment? The patients next ask is, what is the success rate of the treatment? So this success rate of the treatment depends on a lot of factors. Okay, so it depends on the clinical stage, it depends on the histological grade, and there are also other factors which are very important based on the patterns of gene expression and gene mutations. What are the factors responsible for the prognosis within the tumor? Of course, there are a lot of factors which are involved. Okay, among the very many factors which are listed down here, what the research community is interested about is the host response. Okay, so the research community is interested in the host response in terms of the lymphocytic response. Okay, so the previous slide, you remember I told you, once this epithelium enters into a foreign land, it comes into attack by all the lymphocytes and all the immune cells. They have to evade all these. So if this immune response is good, okay, so that it means the prognosis of such patients may be better. I'm not saying it is always better. It may be better in majority of cases. Okay, so in terms of the lymphocytic response and what type of environment is the tumor surrounded by, whether it is an immunosuppressive environment or an immune active environment, okay, will decide will be one of the important prognostic factors. So we will look at this in more detail in the later part of the presentation. So this is an article which says a prognostic nomogram in oral squamous cell carcinoma, the negative impact of low neutrophil and lymphocyte ratio. So which means In a squamous cell carcinoma, in the surrounding vicinity, when the number of lymphocytes and the neutrophils are less, okay, it shows a negative sign. Okay, it is a negative impact on the patient, so where the prognosis is going to be poor. So you can see three different histological pictures here. One showing a weak lymphocyte, or I'll go the other way around. So this is the tumor, and if you see, there is a strong lymphocytic response around which, okay, so which can actually kill up some of the tumor. And this is the tumor which has a very intermediate lymphocytic response, and this is the tumor which has got very weak lymphocytic response. Okay, so coming on to the treatment strategy. So what is the current treatment which is given for patients with oral squamous cell carcinoma? So the treatment will be basically based on a very important criteria which is called as tumor staging, and another one which is called as tumor grading. Okay, so first question again, as a layman, when they ask, okay, what are the chances of this patient surviving, the first question that we ask is, what is the stage of the tumor? Okay, so the stage of the tumor is decided by three important factors, which is called tumor, node, and metastasis, which is given by the American Joint Committee for Cancer. That is called as the TNM staging. So the T actually stands for the size of the tumor. I'm not going into details of all this. Okay. Okay. So the T stands for the size of the tumor. And if you see T1, T2, T3, and T4, each denotes a different size. T1 is the smallest size and T4 is the largest size of a tumor. So T denotes the tumor. So the larger the number, the bigger the tumor is. Next is the involvement of nodes. Okay, so N stands for the lymph nodes, whether it is a single lymph node or whether it is multiple lymph nodes, whether it is on the same side or whether it is on the opposite side. So those are called as the lymph nodal status. And finally, metastasis, meaning whether it has spread to a distant organ or not. Okay, that is called as a metastasis, whether there is a distant spread or not. So this criteria is called as the TNM criteria, which is currently in use for treatment of patients. But unfortunately, these predictors are subjective. Okay, so and they often lack sensitivity, and hence they are relatively unreliable, meaning that very often two tumors with an identical staging and grading behave in a totally different fashion. And although one responds to therapy, the other one is lethal. Okay, and furthermore, these methods also do not reflect the aggressiveness of the tumor, the prognosis, and response to therapy. Okay, so these are the various problems encountered with these TNM staging. Okay, so now these are the different treatment based on the current strategy now is based on the TNM staging. So this is what we do, either a surgery or a chemotherapy or a radiation. Okay, okay. So despite all of this, okay, so despite all of these, okay, so with rapid increase in the multimodal therapy, the number of deaths and the 5-year survival rates have not gone up. Okay, if you see stage 4, okay, stage 4 tumors, okay, still have only a 9% survival rate. So what is the key for improving the survival? If you see stage 1 cases survive for a longer period of time, there is an 85% of 5-year survival rate. So the keys for improved survival and success rates of treatment is early detection. Okay, so the early detection, which is to improve the survival, and for us to identify or to detect it early, we need tools for early detection and monitor disease progression. And currently, the gold standard for this detection is histology. But unfortunately, histology is something that you need to put your scalpel on all the time. It's a lengthy process. Okay, you need to put it under the slide and then do it. So you need alternative for this. Okay, so what are the diagnostic principles? Okay, I think I'll skip this slide. Okay, having had a little bit of knowledge about oral cancer, should an oral cancer be diagnosed easily or a lung cancer be diagnosed easily? Obviously, the answer is oral cancer. The reason being, it is in a readily accessible area, because you can just ask the patient to open the mouth, and if you clearly examine all the areas, okay, there are chances that you might able to visualize some areas which are representing carcinogenic change or the cancerous change. Okay, so it is easy for an oral cancer to be detected rather than a cancer which is there somewhere inside your body. And of course, because it is also associated with known risk factors, you ask the patient, there is a lesion, you ask the patient whether he uses tobacco, then you can correlate. Then you think, yes, this might be oral squamous cell carcinoma, and a precancerous stage before all these invasive lesions. But in spite of all of this, the diagnosis is still late. Okay, because most lesions are asymptomatic, There are very many reactive lesions which can mimic oral squamous cell carcinomas, and many lesions are clinically not apparent. And the most important thing, routine screening by providers or care providers are not a common practice. Okay, so because when you have an oral cancer, the first doctor that a patient goes to is a dentist. Okay, so majority of the times the dentist, okay, so they see only the teeth. Okay, but fortunately, me being an oral pathologist and a clinician together, my first priority is not to see the teeth, to look for the tissues for any change. Okay, so that is how I changed my practice. Okay, so I think I've taken an hour, so a time for a break. Okay, not a break in the sense a real break. So, okay. So now, is early detection really happening? So what do you do with this apple? Okay, when you see this apple in a fridge, obviously you take this apple and eat, and somebody has told you an apple a day keeps the doctor away. Okay, but what do you do with this? Okay, so it's obviously rotten, you throw it out. But what do you do with this? Okay, so when such a patient comes to your clinic, the first thing is you don't raise your eyebrows and think what to do. You don't know what to do. Okay, so what to do, where to refer, and how to manage this patient. Okay, this is the problem with this. Okay, but in our areas, if you get a patient like this, everybody jumps out of the chair, including me. Okay, take your cell phone and take a selfie and put it in all the social medias. Okay, that's not how it is supposed to be. It should be the other way around, right? Okay, so now these are some lesions which are very, very hard to miss. Okay, so these cannot be missed. Okay, if these are missed, then it's a blunder. But what about these lesions? Okay, so these innocuous, innocent appearing lesions on the floor of the mouth and somewhere in the lateral border of the tongue, which are very, very easy to be missed. So if these lesions, and mind you, these are not normal cases, these are cases of oral which are proven to be oral squamous cell carcinomas later. So these are the ones which are actually the trouble givers. Okay, so there is a delay in the diagnosis. Okay, so basically a primary delay, from the patient's point of view, specialist delay from the doctor, and a professional delay to arrange all those surgical dates and things like that. Okay, so I will just skip these little bit slides also. So this result of this delay in the diagnosis is a missed opportunity for early treatment that forces the patient to undergo extended treatment and increased mortality rates. So finally, where have we come? So with all this understanding, now we know the two keys for successful treatment are early diagnosis and appropriate therapy. So how is this to be achieved? So this can be achieved by appropriate communication between the clinician and the research community to identify new tools for early diagnosis and new therapeutic avenues. So are there any new screening and treatment options? Yes, of course, and that is what we are going to look for. Okay, so if you see, okay, so from a pathologist point of view and a clinical point of view, as I told you, although histology is a gold standard, okay, but it takes a lot of time in a remote setting when you don't have a specialist there. It is very, very difficult to do a biopsy, and for screening of oral cancers is very, very difficult. So here comes the role of something which are called as tumor markers. Okay, and this is what we have been for the past decade we have been doing in our with our group in our department. So we've been doing a lot of study on tumor markers for early detection of oral squamous cell carcinoma. I will be touching upon that a little bit also later. So what are these tumor markers? So these tumor markers are nothing but they are biomarkers or biomacromolecules synthesized in excess concentration by a wide variety of neoplastic cells, which can be detected in the biological body fluids. And one such group of tumor markers are the cytokines that we are going to see. Okay, so now these are two different articles, and this one on the right side is one which we have done in our department. So we have done, so being a dentist, okay, apart from estimating these serum biomarkers, we have also tried to correlate these levels of these biomarkers in saliva. Okay, the problem with the serum biomarkers, again the procedure becomes invasive. Okay, it's an invasive procedure, the risk of infection, other problems. So we have tried to see if these levels of serum markers correlate with salivary biomarkers. If the levels of salivary markers are equally good for a diagnosis or equally good for us to predict the prognosis, then it becomes an alternative and attractive option rather than for going in for serum biomarkers. Okay, so now coming, stopping with the biomarker aspect, I will go on to a little bit of your domain, which is the immune aspects of the oral cancer. Now, okay. So what is the biography of this immune system in oral cancer? Okay, so this immune system and oral cancer. Okay, So the relation between these two goes to 13th century. Okay, so there was a person, there was a saint, okay, who had an supposed to be an osteosarcoma of the leg. He was to be operated, but unfortunately, this area, okay, became too big to operate. So I think somebody's audio is on. Okay, if you can mute yourself, please. Okay. Okay, so this was supposed to be operated, but unfortunately it was inoperable. Okay, so what happened was this person and few of his friends, okay, so they all prayed the whole night, and suddenly the next day morning there was no evidence of the tumor at all there. Okay, so then came the concept of spontaneous regression of tumors. This tumor suddenly regressed. They did not know how. Okay, because it was in the 13th century, they did not have a scientific reason for that. Okay, so they thought it was because of some the saint who did all these preaching and things like that. So from then on, this spontaneous regression of tumors was named after this person, which is called Saint Peregrine tumors. Okay, so these tumors were called as Saint Peregrine tumors. They are nothing but in the current era, they are the ones which are called as, or a phenomena which is called as a spontaneous regression of tumor. This happened early in the 13th century. But now this is another report from the UK. In the current era, in the COVID era, this patient was diagnosed with lymphoma. Okay, and they were actually doing it. I mean, he was supposed to have treatment for that, but unfortunately he got COVID. Okay, so he was isolated and things like that. But suddenly after the COVID issue, when the doctors checked upon him, there was absolutely no signs of lymphoma in the patient. Okay, so then they went on to say that this COVID-19, okay, so it triggered the immune system, and this immune system is thought to have fought this lymphoma, and complete lymphoma is gone. Okay, so these are the evidences for the immune system playing a very, very important role in handling these malignancies which are entering. So this is from a 13th century era to the current era which has happened there. So this prompted, okay, there's a little bit of history, but because of I'm running short of time, I'm not going to talk about all that. Okay, a small thing which I've wanted to talk about here is the Cooley's toxin that you all supposed to know. So Cooley's toxin was Cooley was the one who initially prepared a bacterial toxin to give for cancer patients, and that was supposed to heal a few of the cases, and from then on those toxins were called as Cooley's toxin, and later there are a lot of other advances which have actually come in. Okay, and this concept, the idea that the tumors are not entirely self, okay, was proposed by Ehrlich. Okay, so this mechanism was actually called as immune surveillance. Okay, so this is called as immune surveillance, where the immune system identifies cancerous cells and eliminates them before they can cause harm. But despite these tumor surveillance, tumors do develop in the presence of a functioning immune system. And therefore, this concept of immune surveillance was later modified to something which is called as immunoediting, which actually consists of the 3 E's: a phase of elimination, a phase of equilibrium, and a phase of escape, which is self-explanatory. A phase of elimination is when there is a tumor, the immune system identifies this, okay, and via its repertoire, it kills all the cancer cells. But sometimes these cancer cells evade this immune system, and the immune system and the cancer cell coexist in an equilibrium, which is called as an equilibrium phase. And finally, the escape phase, the tumor completely escapes from the attack of the immune system and goes into a full-fledged tumor, which is called as the escape phase. What are the evidences for cancer immunoediting in humans? Okay, a number of clinical observations have provided. Just give me a minute. I'll take some water, please. A number of clinical observations have provided evidence supporting the notion of tumor immune surveillance immune surveillance in humans. Number one, immunosuppressed patients. Immunosuppressed patients have more than 3 to 100-fold risk of developing malignancies. And number two, some types exhibit a particular type of genetic instability, okay, referred to as microsatellite instability, which are seen in tumors. And third is there are something which are called as human tumor infiltrating lymphocytes. Okay, So when these tumor infiltrating lymphocytes are there, so which gives an evidence of there is some immune system working against these tumors. And finally, a paraneoplastic autoimmune syndromes. Patients with tumors experience disease symptoms that are actually caused by the presence of a tumor, but not as a result of a local tumor growth. Okay, these tumors, okay, trigger the production of certain molecules, which will produce certain syndromes in the body, which are called as paraneoplastic syndromes. All these four point to a role for the immune system in suppressing the tumor growth. And now, what is the role of these immune system function and immune response? Now, you know, there are two arms of the immune system. One is their innate and their adaptive immunity. Which arm of the immune system orchestrates the surveillance? Okay, both the innate immunity and the adaptive immunity are involved. And very importantly, the T cells and B cells play a very critical roles here because they develop memory. Upon second exposure to a pathogen, these cells can eliminate a threat much more efficiently because they have learned to recognize and respond to it during a previous first encounter. This potential of the immune system in effectively clearing out antigens are tapped, and a new avenue of therapy has opened up in the last decade, referred to as immunotherapy. And this field of oncology is what is called as immuno-oncology. So the ultimate aim of immunotherapy, okay, for cancer is to educate and then liberate the natural underlying cancer immune responses in the adaptive immune system. Okay, so to have a general overview of what the immune system does to this tumor. So now here what you see is a tumor clone. Okay, so this tumor, okay, presents certain antigens on it, and these antigens are recognized by our antigen presenting cells, or the APCs, such as your Langerhans cells or your dendritic cells. So these antigen presenting cells, okay, which can activate the tumor specific T cells. So this crosstalk between the dendritic and the T cells primarily or typically occurs within the lymph node. Once these T cells are activated, they traffic to the site of the originating tumor. They recognize this tumor-specific antigen on the surface of cancer cells, produce cytokines that help to drive further T cell expansion, and ultimately lyse or kill cancer cells in the tumor microenvironment. Okay, so this is a general overview of how this immunology or how this immune function works. But if this was to be so simple, cancers would have been eradicated some 20, 30 years back. But the challenge is yet to come. Yes, in the sense that this really is a very complicated process, because as I commonly say, tumors are the greatest mutators. They have got their own method of escaping this tumor system, or escaping the immune system. Tumors go to great lengths to evade the immune response. A lot of studies have identified multiple mechanisms by which cancers employ to defeat or evade the immune system. Okay, so a few of those are the immunosuppressive cytokines which are produced by the tumor itself. Okay, namely your TGF beta, the interleukin 4, 6, and 10, and immunosuppressive immune cells, namely your Tregs, your T regulators, and your macrophage, and disruption of your immune activation signaling. So all these are mechanisms by which the tumors try to escape the attack of your immune system. Recently, attention has been paid to the molecular interactions between the tumor cells with the adjacent peritumoral microenvironment, in which immunosuppressive molecular changes create a landscape that promotes tumor progression. Okay, the rationale for the introduction of immunotherapy is to reverse the balance of these immune cells, or reverse the balance of these immune interaction in a way that it utilizes the host immune system to attack tumor cells. Okay, so with this knowledge, there opens a new avenue of therapy, which is called as immunotherapy. So apart from the routine methods of therapy, that is the surgery, chemo, and radiation, there is a new field which is called immuno-oncology, which is supposed to have a few more benefits than the routine cancer treatment. Okay, this slide shows the timeline of development of immunotherapy, starting from the genus, the Cooley's toxin, till date for EGFR targeted therapies for lung cancer and for melanomas as well. So what are the different forms of immunotherapy? So there are different forms of immunotherapy. Okay, this is not in the order of evolution, but still, okay. So the first one is the immune cell therapy, which is called as CAR, that is the chimeric antigen receptor T cell therapy. And then the cytokines, you have monoclonal antibody therapy, the cancer vaccines, and checkpoint inhibitors, each one having its own advantage and disadvantage. So let me talk about the cancer vaccines first. Okay. So what are these cancer vaccines? Cancer vaccine is a vaccine that actually treats the existing cancer or prevents the development of cancer in certain high-risk individuals. Vaccines that treat existing cancers are actually called as therapeutic cancer vaccines. There are different types of cancer vaccines, starting from dendritic cell vaccines, which are actually the antigen-presenting cells which are taken up. They are allowed to identify the antigen and then they are introduced inside. Okay, so these are dendritic antigen vaccines. The second ones are peptide vaccines, which are actually called the antigen vaccines. Okay, so the antigen is taken and then it is injected for its response in other cancers. Then there is something called tumor cell vaccine, where whole tumor cells, okay, whole tumor cells are taken up and then which are injected into the body. So these tumor cell vaccines are again categorized into autologous and allogenic. And then finally, DNA vaccine, where instead of the tumor genes are instead of the antigen itself, genes are actually used, okay, to prepare these vaccines. And finally, the anti-idiotype vaccine, which is nothing but it is based on the idea that antibodies can also act as antigens, triggering an immune response. Okay, so this idea was used to create a vaccine in which the antibodies would be injected into the cancer patient, okay, eliciting an immune response. So what are the current status for cancer vaccines? Okay, so many promising studies have been done till date on which were there in phase 2. Okay, and whole cell vaccines, tumor antigen directed and manipulated oncolytic virus vaccines have been done, okay, in phase 2. But unfortunately, in phase 3 trials, they failed to show survival benefits of these vaccines. Okay, so the only two which showed promising results was the one in prostate cancer and another one in melanoma. What are the actual problems in these cancer vaccines? Okay, the immune system induces an immune reaction against the vaccine, but not the tumor. So that is one important drawback of this cancer vaccines. The immune system mainly recognizes new antigens from passenger mutations rather than the shared antigens. And even if the vaccine enhances anti-tumor immunity, the cell is likely to be suppressed in the microenvironment. So what it means, the vaccines are unlikely to have a major effect in the absence of immune checkpoint control. I will talk about this immune checkpoint control in the next slide. You will understand better. Okay, so now the molecular identification of numerous tumor antigens initially catalyzed or hoped for development of new tumor antigen-based vaccines for the treatment of cancer. However, numerous vaccine approaches in melanoma and other cancers have yielded a low rate of clinical response despite frequent induction of all these T cells into the peripheral blood. So this prompted a lot of investigators to begin interrogating the tumor microenvironment for biological correlation versus tumor response versus the resistance. So there is a lot of evidence which are beginning to emerge suggesting that the distinct subsets of tumor may exist that reflect distinct categories of immune escape. Now here you see two pictures on the slide, one on the left and another one on the right. So this is a non-inflamed tumor phenotype, which means when the tumor is not able, when the environment or the surrounding environment of the tumor is not able to produce a sufficient inflammatory response, the cytotoxic T cells lose their ability to migrate into the tumor. Okay, so this is a non-inflamed subset. Whereas here in an inflamed tumor phenotype, so these cytotoxic cells have the ability to migrate inside, and then they have the ability to cause toxicity to these tumor cells and cause their elimination. But unfortunately, here also tumors have found an alternative mechanism to escape this T cell. If you know, these T cells have got regular T cell receptors at them. And then they've also got something which are called as checkpoint inhibitors, or the checkpoints on the T cells, because you don't want the T cells to unnecessarily activate death of other cells. So there are something which are called as checkpoints on the T cell. So what these tumor cells have done is they have evolved a mechanism of creating a receptor for this checkpoint, and they attach to that and they render this T cell inactive, or they abuse these checkpoints on the T cell, and they utilize this and they escape this T cell attack. And that is why later the checkpoint inhibitors came into the picture for treatment. So these are the checkpoint inhibitors. Okay, so if you see, if I'll put a next picture. So if you see this is a T cell and this is an antigen. If you see, this T cell has got a regular T cell receptor, which when bound to an antigen and identifies it as a defective cell, it tries to kill. But it does not, but it should not kill all cells. So there is something which is called as a checkpoint here. That is the programmed death receptor PD1 and PDL1 and CTLA4, which are actually there. Tumors evolved a mechanism of creating this PDL1, and they bind to this and they make this T cell inactive. So what these checkpoint inhibitors do, okay, so checkpoint inhibitors are those drugs which block this connection between this PD1 and the ligand which is there in the tumor. So this is how these checkpoint inhibitors work, and this was the one which was advantageous than the cancer vaccines. Till date, there are a lot of immunotherapeutic agents which are there in clinical trials. That is the CTLA4. These are called the checkpoint inhibitors, which are the CTLA4, the PD1, and the PDL1. Okay, so these are very active checkpoint inhibitors which are currently in use. Okay, so the next important topic that we're going to talk about are the cytokines. What are these cytokines basically? The development of an active or an effective immune response involves lymphoid cells, their inflammatory cells, and hematopoietic cells. The complex interaction among these cells are mediated by a group of proteins which are collectively designated as cytokines to denote their role in cell-to-cell communication. Okay, these cytokines are nothing but low molecular weight regulatory proteins. So these are low molecular weight regulatory proteins or glycoproteins secreted by the white blood cells and various other cells in the body in response to a number of stimuli. They act as intercellular mediators to regulate homeostasis of the immune system. The cytokine effects also depends on a lot of factors such as the local cytokine concentration, cytokine receptor expression, and so on and so forth. So these are basically cytokines. So these cytokines are given different names based on the cell from which they are produced, but they have a general name which are called cytokines. If they are produced by the mononuclear phagocytes, they are called monokines. From the lymphocytes, they are called lymphokines. And interleukins are the ones which are made to interact between one leukocyte to another leukocyte. That is why it is called as interleukins. And chemokines are nothing but another group of cytokines, a small group of cytokines which aid in the chemotactic activities. And finally, interferons, which are produced for antiviral response. So these cytokines put together, they have an action of either a pro-inflammatory or anti-inflammatory effect. But sometimes a single cytokine can also have both pro-inflammatory and an anti-inflammatory effect as well. Okay, so coming on to the properties. So once a particular cell produces a cytokine, it can act on the cell that it has produced. It can act on the cell that it is produced by. So these activities are called autocrine activities. If the cell produces a cytokine and it acts on a different cell or a nearby cell, those are called paracrine activities. And if it enters the blood vessel, okay, and it is carried to a different site to produce its effects, they are called endocrine activities. So these are the basic properties of cytokines: the autocrine, paracrine, and endocrine. What are the attributes of the cytokines? The attributes of cytokines are pleiotrophy, which means a single cell can produce a cytokine which can act on multiple cells. Redundancy, the same cell can produce a different number of cytokines which is acting on a single cell. Synergy, when two different cytokines act together in synergy. Antagonism is just the opposite of that. And cascade induction is one cytokine causing activation of another cytokine and so on and so forth to enter into a cycle. And finally, coming on to the functions, okay, in a nutshell, the entire functions of cytokines are basically an inflammatory response, the hematopoietic regulation, development of the immune system, control the proliferation of cells, differentiation of the cells, and wound healing. So there are different cytokines which are there. I'm not going into details of all these cytokines. Okay, there are a lot of cytokines till date which have been identified. Okay, so namely your interleukins, that is interleukin 1, 6, 8, 12, 17, and so on, TNF alpha, which are very, very important, the interferon gamma, which is very, very important. Okay, I'll skip these. And okay, so let me talk about a few cytokines which are actually put into use. Okay, so I have taken up few cytokines which we have actually worked on in our department. So I've just taken up those cytokines alone. Okay, so the first one that I'm going to talk about is a tumor necrosis factor alpha. Okay, so what exactly is this tumor necrosis factor alpha? Just a moment. Okay, so these tumor necrosis factor alpha is a pleiotropic cytokine which acts on a large variety of cells with wide-ranging effects on individual cells. See, amongst the hematopoietic actions of TNF are the activation of macrophages, monocytes, lymphocytes, neutrophils, and the promotion of coagulation. So this TNF alpha is a cytokine that is produced early in the inflammatory cascade and has shown to promote carcinogenesis. Okay, before that, I need to talk about something very important. Okay, the molecular biology era, okay, the current era where we do a lot of molecular biology studies, the molecular biology era brought with it the discovery of such new cytokines and chemokines that could actually activate and direct leukocytes in a coordinated fashion, and alternatively could also participate in tumor progression. Taking cue from this, clinical applications soon followed, and chemokines and cytokine immunotherapies heralded promise of a new wave of cancer treatment. Okay, that is how this cytokine came into existence. So this is one such cytokine, that is the tumor necrosis factor alpha, which holds a lot of promise in as a biomarker. So now this tumor necrosis factor alpha, okay, so the study which was done actually in our department was, so this tumor necrosis factor alpha, the levels of this tumor necrosis factor alpha was studied in oral cancer and pre-malignant lesions as well. So initially, remember I said when I spoke about how important the pre-malignant lesions are there. So if you are able to identify some change at the pre-malignant stage itself, the chances of successful therapy and successful survival of the patient is more. So this is what we see here. So we compared the levels of these TNF alpha, the biomarker TNF alpha in the serum and the saliva of patients with oral pre-malignant lesions and malignant. So what it showed was there was a significant increase, okay, significant increase in the levels of TNF alpha in oral squamous cell carcinoma patients when compared with precancerous lesions and when compared with normal patients. So which means the normal patients had a lower level of TNF alpha, whereas the oral cancer patients had a higher level of TNF alpha. And apart from this, we also try to correlate the levels of serum and the saliva. So what you can see is as the levels of serum are there, the salivary levels are also been shown are also increased. So which means this TNF alpha as a biomarker for indicating or telling us that the prognosis is going to be bad can be used as a potential biomarker. So what you see here is the comparison of TNF alpha in different clinical stages and histological stages as well. So we tried to correlate if there was any significant increase from a very early stage to a late stage. So there was an exponential increase in the levels of this TNF alpha from the early stage cancer to an advanced stage cancer. So which means that this TNF alpha, okay, this tumor necrosis factor alpha could be used as a prognostic marker for this oral squamous cell carcinoma. Apart from this being used as a prognostic marker, this TNF alpha therapy has also been tried in many of the cancers, but unfortunately the results of TNF alpha therapy has not yielded good results. So this is not in use anymore. Okay, so this but this TNF alpha can be used as a potential biomarker for early diagnosis of oral cancers. Similarly, there is another marker which was also studied, which is called interleukin-6. So what exactly is this interleukin-6? This interleukin-6 again is an interleukin. The classical signaling of this interleukin-6 is considered essential for homeostatic process. But whereas the trans signaling was specifically demonstrated to amplify inflammation and promote inflammation-induced carcinogenesis. So which means apart from your immune system producing the cytokine, the tumor cells also have a way of producing this interleukin-6, and they used it to their advantage to promote carcinogenesis. Okay, so how does this carcinogenesis is promoted? Is they actually activated the Janus kinase and the signal transducer and activator of transcription pathways, and there was excessive abundance of this IL-6, and there were a lot of mutations which are happening. Okay, in addition to its ability to amplify pro-carcinogenic chronic inflammation, IL-6 also drives, as I told you before, IL-6 also drives tumor intrinsic mechanisms of cancer progression that actually recapitulates many of the hallmarks of oral cancer. Okay, and apart from that, they also induce angiogenesis. Angiogenesis is a very, very important hallmark which is required for the cancers to grow. So via the VEGF, angiogenesis was increased, and the tumors can survive for a longer time and they can self-sustain. So this was another marker which was studied, a very similar study where we tried to see interleukin-6 in pre-malignant lesions and oral squamous cell carcinoma. We very similar results, similar to TNF-alpha, where we found increasing levels of interleukin-6 in various grades of oral squamous cell carcinoma and different clinical staging of oral squamous cell carcinoma as well. So this was another marker. And finally, two other important things that you need to know. So the reason why I put this, maybe from your point of view, where Arvind sir is more into tuberculosis and things like that. So that was another one. Okay. So that is the secretory leukocyte protease inhibitor. So if you all know this SLPI, this secretory leukocyte protease inhibitor functions as an endogenous immunomodulatory and anti-inflammatory, and has got antimicrobial properties as well. So now this has got its profound effects on the Mycobacterium tuberculosis. So the SLPI, the majority of the studies in the literature, if you see, this SLPI would be done against Mycobacterium tuberculosis and in HIV as well. Okay, the importance of this SLPI is, if you know HIV, okay, HIV is known to spread through body fluids and through physical contact. Okay, but the HIV, surprisingly, it did not spread through saliva. So it was speculated what was the reason. So the reason for that was found to be one important enzyme which is inhibited, this SLPI, which is there, which inhibited the transmission or the growth of HIV in the saliva. So the reason why HIV does not spread through saliva was because of this secretory leukocyte protease inhibitor, and this secretory leukocyte protease inhibitor is extensively studied in lung carcinomas. And for us to see whether if this has got any effect in the oral cavity, or it could be used as a biomarker in oral cavity, oral cancer, we try to study this in oral cancer as well. And finally, coming on to the salivary HER2/neu. This HER2 actually belongs to a group of human epidermal growth factor receptor family, which includes EGFR, which is the HER1, HER2, and HER2, HER3, and HER4 as well. Okay, so what does these do? They regulate the cell growth, survival, and differentiation via multiple signal transduction pathways and participate in cellular proliferation. Majority of these HER2 have been studies in HER2 have been carried out in breast cancer with increasing understanding of HER2 biology. And now it is understood that these HER2 can also be can actually play a role in other cancers also, including your stomach, lung, head and neck, and esophageal cancer. And if you know, currently there are two drugs, anti-cancer drugs, which are used for non-small cell lung carcinomas. Okay, so there are small cell lung carcinomas which are used to inhibit this EGFR. So this salivary HER2 levels were also studied in oral cancer, which showed promising results which we can use it as a potential biomarker. And coming on to the last part of my presentation, something which is called as a CAR cell therapy, which is called as chimeric antigen receptor T cell therapy. So this is a new technology which is used. This is a type of treatment in which patients' T cells are genetically altered, so they will attack cancer cells. So these T cells are taken from a patient's blood. Then the gene for a special receptor that binds to a certain protein in the patient's cancer cell is added to the T cell. So this special receptor is actually called as the chimeric antigen receptor. And these large number of these CAR cells, okay, are grown in the laboratory and given to the patient by infusion. So currently this CAR cell therapy is used for treat certain blood cancers, and is currently being studied in the treatment of other types of cancers as well. And finally, to end with this CAR cell therapy, okay, And when the entire country was locking itself down, the relentlessly working researchers have created the first CAR T cell therapy, and this is one of the most the first gene therapy in India. Okay, the reasons are the CAR cell therapy is actually in use in US and other countries, but because of its cost, we were not able to do this therapy. But in the 4th of June, that is the year 2021, the first CAR cell therapy clinical trials were approved, and very soon we will be seeing the usage of this CAR cell therapy in our country as well. Okay, and finally, to conclude this presentation, cancer treatment is one of the challenging aspects in the medical field, and the treatment modalities ranging from surgery to chemotherapy and radiation have yielded mixed results. To overcome this hurdle, newer innovative approaches are needed to reduce the morbidity and mortality of these patients. Immunotherapy is one of the newer entities that is promising, at least can be very much helpful as an adjuvant therapy. The disadvantages of surgery, such as the recurrence of tumor and non-resectable lesions and toxicity of radiotherapy or chemotherapy, can be substantially reduced by immunotherapy. This newer modality of the treatment in the field of cancer treatment may become the 4th pillar supporting surgery, chemotherapy, and the radiotherapy. But however, careful selection of patient is the key for success rate of immunotherapy, which is based on the patient's immunological context. So this is how I finally want to conclude. And finally, on the future directions, this is what me and Aravindan sir actually discussed a few days back, okay, when we submitted a project for ICMR. Usually all these immunotherapy drugs are used only after other treatments have failed and a patient's cancer has spread. But imagine in a pre-operative setting will be very, very interesting, because patients' immune systems haven't been affected by a prior treatment. The tumor will actually be in place to serve as a focal point for immune response. So it may be easier for the body's immune system to recognize and target the tumor. If this futuristic view, okay, is achieved, then probably in near future there can be successful treatment plans or successful therapies which can be advocated for patients and for successful prognosis and longevity of these patients. Thank you very much.
Thank you so much for the lucid presentation, sir. It was information packed, exact more than 1 hour presentation, and the way you delivered the talk was purely amazing. I mean, there was absolutely no ups and downs, and it was a steady flow of information. And I'm sure like students would have understood each and every bit of it, and they would have also enjoyed this one, because they basically have a paper in gene therapy. And almost many of the things which you have said, they have already heard about it in the gene therapy in a very, very brief manner. CAR T cells, immune checkpoint inhibitors, and things like that. So definitely, this is one of the seminars which I personally feel would also help them in their examination, because now they have got additional information about the syllabus, whatever was covered in the syllabus. So once again, I thank you immensely for taking your time off and then coming and giving a talk for us. And another thing is, this is the first talk from a clinician in our immunogenetics workshop. Till date, all the genetic people were giving the talk. And this is also the first immunology talk. Till date, all the talks were either biostatistics or genetics. So once again, I really thank you.